last talk by Kelly, why would a medical oncologist be involved in sarcoid? But I have been. In fact, I was proud enough to publish my first paper in sarcoid in the 1980s, so I've been very involved in sarcoidosis for quite some time. And the reason I became involved in sarcoid because I'm at the University of Cincinnati, and you're actually going to meet my husband, Bob Bachman, a little bit later today. And as a pulmonologist, he loves sarcoid. He breathed, ate everything sarcoidosis. And he said one day, I have all these patients that are on steroids, and they have all these horrible side effects. We need to look at something else. And so back at that time, we decided that some of the drugs that we use to treat cancers, such as methotrexate, could perhaps be utilized for the treatment of sarcoidosis and some of those steroid-sparing drugs. And so that's really how I've been involved. And so over the last 4 decades that I probably care to count, we've been looking at a variety of drugs. So that's the background that I come from. But I'm not going to be talking today about treatment that much. A little bit on treatment, but basically it's kind of the smorgasbord in the background behind the sarcoid. I'd like to query you and ask, how many of you have been diagnosed within the last 6 months? Okay. How many of you have been diagnosed more than 5 years ago? Okay. So, and that's often the case. Many of the sarcoid meetings are people brand new diagnosis, and I have to say some of the first comments you heard probably scared the daylights out of you. Because you're sitting there going, am I going to be sick forever? So we're going to talk a little bit about how long you might be sick, who is sick longer, how we make some of these decisions. And so with that, I have an outline of 5 bullet points, and we will try to definitely stay on time. We're going to talk a little bit about epidemiology, something that we call sarcoid phenotypes. That basically means where are those granulomatous lesions identified in your body. You've already heard from Andrea, the co-founder, and others that it affects every part of your body. Indications for treatment, and then something called parasarcoidosis, which you probably never heard of, but I will wager all of you that raised your hands that said you've had sarcoid for more than 5 years will know exactly what I'm talking about. And then we're going to summarize. So first of all, sarcoid is a global disease. As you saw from the slides from Kelly, we have research going around all around the world. And one of the fun things about this disease is that there's some similarity and commonality regardless of where you live. Now, recently, we've decided to look more in depth about what's actually the prevalence of sarcoid in the United States. And as you can see, the West Coast has about half the prevalence of sarcoid compared to the Midwest. And we're up there in green on this kind of cool, windy day in Chicago. The South actually has about the same prevalence as does the Northeast. So it's pretty much anywhere a little bit less identified in the West. So what about racial and ethnic prevalence of sarcoid? It affects both men and women. We still see that sarcoid can affect women a little bit more than it affects men. And females are on the blue bars there, and men are on the yellow bars. The African American race in the United States still has a little bit higher prevalence of sarcoid compared to Spanish, Asians, and Caucasians. So what is this thing called sarcoid? Believe it or not, it's one of the few diseases remaining in which we don't know the cause. And that's probably one of the big reasons why research has been somewhat difficult. And it's also difficult because we do not have a test that we can do that tells you that you have sarcoid. That's pretty frustrating. So you have to find the presence of non-caseating granulomas. And granulomas have to be seen in a clinical setting in which we don't see any other cause. Now, granulomas can be something that just clusters of inflammatory cells. It's just inflammation, like joint inflammation or pleurisy. It's a collection of white cells, as you see on the right-hand panel. Is there a pointer on here, Kelly? No, okay. And the action is in the middle of the granuloma, and that's where there's what they call the football huddle. That's where all the soup is, and all the cytokines, and the white cells that talk to each other and release substances. And there are many things that can cause this granuloma when the pathologist looks at it through the microscope. And so they have to do extensive testing. So one of the first things is sometimes you'll go in, like the lady earlier today said, I went in, I was sick, they did an x-ray, they said you have sarcoid. You might be pretty sure of that, but most of the time you have to have a biopsy, and that's because you want to see the presence of these granulomas, and you want to make sure that there's no signs of infection. Cancers can also sometimes be associated with granuloma, and even the presence of metal, like beryllium, can sometimes cause a reaction. So the granuloma is a reaction to something that we have been exposed to. And in sarcoid, we now believe that the exposure that causes this reaction varies. And that's one of the reasons why we don't know a specific etiology. It might be an infection in some, it might be a stressor in another, we don't know for sure. And people are still working on that, as they have been for quite some time. Now, one of the clear-cut things is not just seeing granulomas, but you have to have the right clinical setting. And if you see several organs involved, and you've already heard from a couple speakers, they said, well, they found it in my lungs, then they saw it in my heart, then they saw it in my bones, then they saw it in my skin. So the more organs that you see that have granuloma, the greater the likelihood that this is truly the diagnosis of sarcoidosis. But there's one caveat here. You can never be 100% sure of the diagnosis, which is sometimes frustrating, not just for you as people, but also for us that help to take care of you. Now, this slide illustrates that sarcoid can affect any organ in the body. The lungs still remain the predominant one. You see that big circle of 89%. But it can affect the eyes, and you're going to hear a speaker that talks about that. It can affect the nervous system. Dr. Tabby, I think, speaking after me. It can affect the heart. The skin's a commonplace, joints. So any part of the body can unfortunately have sarcoidosis. Now, having a granuloma present in any part of the body does not mean that you have to have treatment. It doesn't mean that that's a bad finding. And that gets back to this concept of what we call acute versus chronic sarcoid. And this is actually a slide taken from one of your colleagues that has sarcoid. Gee, and the chronic version, how sad. That's the one I've got, hooray. So you'll hear people talk about, am I going to have this thing forever? Am I going to have this thing for 6 months or a year? And there are many people who have sarcoidosis that have it a very short time period, and it totally goes away. And in fact, sometimes they forget they got diagnosed with it 20 years ago when they were in the service. There are other people that have a chronic form of sarcoid that unfortunately will continue to plague you and can cause problems probably pretty much the rest of your life. So one of the important things when you're first diagnosed is trying to get a sense of, do I have acute problems, do I have chronic problems? And we're always trying to search for easy ways to look at that. So one of the best identified acute problems of sarcoid that spontaneously resolves and usually requires no treatment is something called Compartment Syndrome. First identified by our Swedish colleagues. We do see it pretty much in any country in the world. And this is a presentation of someone with Compartment Syndrome. They have these potato nodes, as you see in the chest x-ray. They have red spots on their legs. They feel achy, kind of like they have the flu, and they have some arthritic type symptoms. Usually people with long prints require no therapy, usually, and they can get treated with steroids on their skin or something to help with the rash to make them more comfortable. But most of the time, that totally goes away and never returns. In contrast, you might have one of these other more chronic findings. And so when you have eye disease, which you'll hear more about, that's usually a marker of a more chronic process in sarcoid. And we always tell our patients, if you've had eye sarcoid or if you have a diagnosis of sarcoid, when you see your eye doctor, tell them you've been diagnosed with sarcoid, because you want to make sure that you have an eye exam done. Skin lesions. There are some skin lesions, as seen by the lady on our second panel. She's one of the patients from our clinic. This is called lupus pernio, and that's a marker of chronic disease. That lady will probably have problems with skin lesions pretty much the rest of her life. That's what we say today. Hopefully that's not what we say in 2020 with newer strategies. In contrast, little skin lesions may be very acute and they totally go away. So you have to look at the pattern, and I know you'll hear more about that. Finding granulomas in the liver, that's the third panel here, does not mean that you need treatment. In fact, it's very common to find granulomas. You don't have to have therapy for that. It's usually asymptomatic. But it's a marker that you still have that continuing inflammatory process ongoing. Some patients with sarcoid will have problems with calcium, and sometimes patients will actually present with kidney stones. And that's often a marker of a more serious issue that could continue down the road. And it gets very dicey when you have to talk with your primary care doctor about, can I take vitamin D or not? That's a discussion we're not going to get into today, but I would encourage you to make sure you're very cautious when you have sarcoid, when they talk to you about vitamin D replacement. We also know that lung disease can have various manifestations. You can have those nodes that we saw in the chest that go along with Lockhart syndrome, but the opposite end of the spectrum, you may have fibrosis in your lungs, which can imply a chronic nature that's probably going to bother you a lot more down the road. And then if you have heart problems, that's often a more chronic process. So sometimes when you're first diagnosed, we can get a sense of whether we believe the disease has a tendency to be chronic, meaning it lasts more than 2 to 5 years, or whether we think it's something that's going to go away very quickly and be a very little problem for you. Now, we talk about the stages of sarcoidosis, and I kind of laugh about this. Remember, I told you I'm an oncologist. Well, you probably know in cancer, we talk a lot about staging. Stage 4 is the most advanced, stage 1 is really early stage. Sarcoid staging has nothing to do with how widespread the disease is. When they talk about staging in sarcoid, it's only pulmonary sarcoid and it's only a chest x-ray. But it's a good way for us to be able to communicate with each other about how advanced we think the disease may be and how likely you are to have more symptoms from it. So this is a slide on the top panel of stages 1 through 4, and the top panel you'll see the nodes at stage 1, stage 2, there's some nodal disease, and as you can see by the CAT scan below it, there's also some parenchymal involvement. Stage 3, the nodes are gone, but the parenchymal involvement persists. And then stage 4, which is the more advanced disease, it shows fibrosis. Now, why is that important? Well, we learned a number of years ago by an NIH-supported study called Access that if you had a lower stage CAT scan, you had a better pulmonary function, meaning how far you could walk, how you would breathe. And this is shown by this slide. So patients that had stage 4 disease on the far right had worse pulmonary function tests compared to those that had stage 0 or stage 1 disease. So again, it's a marker of pulmonary involvement as to how advanced the disease process may be and how likely you are to potentially develop complications. Recently, we have been very lucky to have something proposed called Wells Law. And we batted back and forth for a number of years. Who gets treatment? How long do they get treated? What do they get treated with? And Alpha Wells was a very famous professor at the Brompton's Hospital in London. And he said, let's be simple here. Why do we need to treat sarcoid? And the only reason to treat sarcoidosis is really twofold: to avoid danger or to improve quality of life. It's not a disease you cure. It is a disease that if it affects certain organs can be quality of life affecting, but it's also a disease that can be dangerous. And so it behooves us when we talk about treatment to figure out, is this a danger? Am I going to go blind? Am I going to have cardiac problems? Am I going to have seizures and have neurologic involvement? Those are danger signs. Those require therapy, and they often require long-term therapy. In contrast, a few skin lesions on your leg may not require any therapy whatsoever. A nagging cough may require some supportive therapy, but not a lot of therapy. So trying to determine, do we need treatment for danger? Do we need treatment for quality of life? So we've recently queried, both us as physicians and patients, on when do we decide we want treated. So healthcare providers like objective measurements. We've been taught we like to measure things. We check your blood pressure, we check your blood sugar, we check your cholesterol. We like numbers. So pulmonary function tests, which are breathing tests, and I suspect pretty much everybody in this room has had those, are something that patients don't like doing, but something that doctors like to see, as is that 6-minute walk distance that Kelly talked about. So we like chest x-rays, we like pulmonary function tests, we look at side effects, and we often look at blood tests. And traditionally, that was kind of the scenario and how we thought about, gee, that patient needs treatment because their chest x-ray is getting worse. Patients, and we're all patients at some point in time, patients said, I like quality of life, I want to function, I want to survive, and I'm concerned about adverse events. So recently, we've dealt a little bit more in depth and surveyed patients to find out what are the most important factors to patients. And number one was quality of life. I don't think I'm telling you anything that you wouldn't already know. And that's that level of well-being. And this includes physical and mental health. Functionality was number 2. You want to be able to take care of your children, work, play tennis, garden, enjoy sports, function. Survival. Obviously, we want to live as long as we can with our best quality of life. Very, very important. A little lesser important was, what did my chest x-ray look like today? So you don't necessarily need chest x-rays every day if you're feeling great and your function's great. What about adverse events? What about blood tests? Just because my ACE level went up or down, that is not an indication that you need any form of therapy. And then pulmonary function test. I think patients just hate doing them. They're not that much fun. But obviously, that's not something that patients think we should use when we make decisions about therapy. So how do we decide? Well, basically, when you have symptoms and we're thinking about quality of life issues, we go down a very quick algorithm. And on the left, you'll see granulomatous inflammation. And in general, we just use anti-inflammatory therapy. And that might be skin creams, that might be prednisone. But if we get into this middle category of complications of the disease, we look at two basic areas. Are they associated with fibrosis? Fibrosis is scarring. That's where that granuloma gets all scarred down. In fact, you may not even see a granuloma there anymore. But we know that those are the patients that can get into more life-threatening issues. You can get all kinds of bad pulmonary problems. You can get pulmonary hypertension, the development of fungus balls. Those are more serious complications associated with the development of fibrosis. Not associated with fibrosis are things that plague patients most. Fatigue, small fiber neuropathy. Those are issues that all of us sometimes will feel, and they can be those nagging things, and we're going to spend some time talking about that. And then on the far right are complications of therapy, and I'm not going to delve into that today, but that's something that you need to talk over with whoever manages your sarcoid care. How do I manage osteoporosis, diabetes, infections, drug reactions? So simplistically, when we talk about lines of therapy, we start with no therapy. And many patients require very little to no therapy. Remember, why do we treat? Avoid danger, or we treat temporary quality of life. If you need therapy, and many patients when they first get diagnosed do because they're symptomatic, usually are first-line steroids. And you already heard everybody groan when that word P came up, the prednisone word, because probably everybody here has heard of that. Second-line therapy is important to consider, and we as physicians feel very strongly that patients shouldn't be on lots and lots of prednisone. You shouldn't just be given steroids every time you come through the doctor's office and you say, I'm coughing more, we'll go up 20 on your prednisone. That's not the right answer. If you still need additional therapy, then there are steroid-sparing agents such as methotrexate, azathioprine, levonomide, and mycophenolate that could be tried. Third-line therapy gets into the anti-TNF drugs such as infliximab, adalimumab, that's Humira, and Remicade. And then fourth-line therapies are very important too, and they're often for those patients that have that chronic form of disease, maybe cardiac, very bad pulmonary disease, central nervous system disease. And Dr. Hoffman's going to talk more about that a little bit later today. So one of the key things that we've learned is we really want to minimize prednisone and its side effects. I think we all know the side effects of steroids. I don't think I have to go through that litany with anybody here. But if you identify someone that's going to need steroids for a long time period, you should start thinking about that second-line therapy sooner rather than later. And worldwide, that second-line therapy most utilized is methotrexate. Azathioprine is used a little bit more in Europe than in the United States. And then there are others such as mycophenolate who have had less studies so far. But it's important to identify that person that may need long-term therapy so that you cannot subject them to steroids forever and a year and think about an alternative. Now, as I said, some people are going to need third-line treatment, and this was actually the first reported case of a sarcoid patient, published case, I should say, of a sarcoid patient who was treated with infliximab or Remicade, and she had horrible skin lesions which were cosmetic, very, very problematic for her. And after 3 months of treatment, they pretty much vanished, which was a great hit for her. And there are a whole host of new therapies, so stay tuned. There are things in the pipeline that are being evaluated to help to treat the nagging systems as well as the potential life-threatening complications of sarcoid. I want to spend the last few minutes on quality of life indicators because that's something we sometimes skirt around because they're the hard ones to talk about. But that's what's important. And I'd like to throw this concept out to you, which is pretty new even to our physicians. And this is something called parasarcoidosis. And parasarcoid symptoms are troublesome symptoms that we see in sarcoid patients. They're not directly related to the presence of those granulomas. So they're often seen in patients that have had chronic disease. The sarcoid inflammation granuloma is pretty well taken care of, but we still have nagging bad symptoms. And this is a saying from a patient that says she went in and the doctor said, "You're great, your CAT scan is normal, your PFTs are normal, you're disease-free." She turned to him and said, "But I'm not free of the disease." So it's a post-inflammatory fatigue, cognitive complaint, and often pain. Anybody here have any of those? Yeah. So. Now I have to tell you, it's not just sarcoid that we see this in. We also see this in my patients. I take care of breast cancer patients the other days when I'm not in sarcoid clinic. And my breast cancer patients, when they're through with treatment, have the same kinds of issues. So sometimes it's this chronic disease. These are tough things, but this is what makes us tick. This is what it helps us to function. And so we need to better put our hands around these, both as patients and as physicians and care providers, to come up with strategies to help you to deal with these. Because remember, that was the number one thing that you as a group identified as being important. So these parasarcoid symptoms are debilitating, and the key thing is they occur in the setting of no signs of active sarcoid. So guess what? If you have more and more fatigue, me giving you 20 more milligrams of prednisone is not going to work. So treatment for sarcoid does not improve these conditions. This is not an inflammatory reaction. So the big three, fatigue, and I'm going to spend most of our time drilling down on that. Small fiber neuropathy, and I know Dr. Tabby's probably going to cover that on this end. Just a few things, because small fiber neuropathy is one of the main causes of fatigue in sarcoid. And then this other thing called cognitive failure. You know, where your head feels like spaghetti. You stand up to, talk, or you stand up to go to the grocery store, and it's like, I've got 6 things on my list, and I only remember one of them, and I'm a Rhodes Scholar. What's wrong with this? I can't do this. So we're going to drill down a little bit on those. So fatigue, very, very common. 80% of sarcoid patients will experience fatigue, and I suspect some of you are already fatigued just from this being our 3rd lecture already. But maybe after I get finished here, we'll let you stand up, because I think everybody needs a little bit of a break. But sarcoid fatigue is not the kind of fatigue you have because you didn't sleep last night because your dog barked. It's the kind of fatigue that is nagging. It doesn't go away if you have 12 hours of sleep. It is something that is much more intrinsic. It is hard. It could be from inflammation. It could be from psychological factors, depression, anxiety. It may be organ involvement. If your joints don't work well, you get tired, you get more fatigued. It can be related to other diseases. If you've been on steroids, you now may be diabetic. You may have thyroid problems. It may be from medicines. Steroids and other drugs have side effects. It could be because you can't really breathe. It's just such an effort of breathing that you're very fatigued. Could be from muscles involved or pulmonary hypertension. So how do we try to drill down on this? Well, we know it's common, and actually our Dutch colleagues way back in the early 2000s were the first to start talking about this. And I have to say, at some of the big medical meetings with physicians, there's some doctor kind of saying, that's not a big problem with my patients, they're all fine. That probably was not really true. And they kept harping on us until we in the United States started becoming much more cognizant of this and started doing our own investigation. We did a study with our Dutch colleagues, me meaning from the University of Cincinnati, and we found that our patients in Cincinnati had the same amount of fatigue as our Dutch colleagues did. They had more severe fatigue, despite the fact that our patients actually had worse pulmonary function. We had lower FVCs in our patients, but the Dutch had more fatigue. So how do we assess this fatigue? Well, the first thing out of the chute is make sure you do have those granulomas under control. Make sure the sarcoid is under control. If it's not, try to get it under control. If it's under control, look for other diseases. Make sure they're not diabetic, anemic, thyroid's not a major issue. You want to check for depression and anxiety, very common problems. They require a different intervention. But another very important thing is that you look for sleep problems. 70% of patients with chronic sarcoid have sleep issues. Those sleep issues may be excessive daytime sleepiness, it may be obstructive sleep apnea, or it may be insomnia. So several studies have identified this to be extremely common, particularly in patients with pulmonary disease, but in other forms of sarcoid. That can be treated very differently, and you may feel much, much better and a lot less fatigue. So try to drill down on that if at all possible. Yes, ma'am.
I was just thinking that sometimes you can ask the person, how do you get ready to go to sleep? And they can tell you, write it down. You can talk it over and see if there's something that they could be doing.
Yeah, and you're right. I think this involves a conversation and a chat with you and your healthcare team because they can sort through some of the issues that can be ongoing. Pain is a problem. Fibromyalgia is a probably very poorly recognized pain syndrome seen in many of our sarcoid patients. And it's a chronic, unexplained, widespread pain disorder. And guess what? Pain and fatigue are its common manifestations. And there are some drugs approved in the United States that will help you to manage fibromyalgia. Small fiber neuropathy is another problem. And I won't spend a lot of time on this because I'm pretty sure Dr. Tabby will talk about it as well. But it's a diagnosis that our Dutch colleagues way back again in 2001 said occurred in about 30% of their patients that had pain. It's a sharp, shooty, electrical, sometimes light touch evoked pain. It can be anywhere. It can come and go. It has many other symptoms that can be associated to it, and it's all related to damage to small fiber nerves in the skin, as well as problems with what we call the autonomic nerves. That's our sweating, our GI, and other mechanisms. And guess what? One of the main issues with small fiber neuropathy, in addition to the pain, is fatigue, anxiety, and insomnia. It's difficult to diagnose because the physical exam and EMGs can be normal, and skin biopsies and newer eye techniques, one called confocal microscopy, can help us diagnose that. Treatment's problematic, and I bet, Dr. Tabby, you're going to talk about that? Or, yeah, we're going to skip that. So what do we do when we have persistent fatigue? How do we recharge the battery here? What are some other options? Well, about 6 months ago, a study came out looking at 6 interventions that had been proven in what they called peer-reviewed journal articles that address treatment options for the control of fatigue in sarcoid patients. And the 6 interventions they identified included 2 anti-TNF drugs, Remicade and Fleximib, Adalimumab or Humira, Aero-290, which is a drug that Dr. Tabby will probably talk about, has been used with some success for the treatment of small fiber neuropathy. Methylphenolate and amiodarone, those are central nervous system stimulants, similar to Ritalin, given to airplane pilots and children and adults with attention deficit disorders, and exercise. So those were the 6. And they found that there was support for anti-TNF therapy and for the neurostimulants, methylphenolate and normodafinil. Again, those are drugs very similar to Ritalin. But there was a caveat. The numbers were small, and patients had been treated with short durations of therapy. But they did work. This is actually a study that we published a few years ago looking at dexmethylphenolate. It's called Focalin, which is a cousin to Ritalin, in patients with sarcoid with chronic fatigue. And we were able to show a 30% improvement in fatigue in those patients when they took the drug. And the patients acted as their own, what we call controls. Half the time you got the drug, half the time you got a placebo. Because you can imagine fatigue's hard to study because we're all tired from time to time. You were blinded, we were blinded, no one knew which drug you were getting. And when you were on the real drug, you experienced fatigue 30% less than when you were receiving the placebo. That was shown in another study with another CNS drug as well. So it is definitely something to consider if you have that persistent nagging fatigue. What about exercise? Most other chronic diseases, exercise is something that we're talking about. Our Dutch colleagues, again, did a small retrospective study looking at the impact on dedicated physical training and exercise and the improvement in fatigue and something we call that 6-minute walk distance. And about half the patients, 49 of them, elected to complete training, about 41 chose not to. And what they were able to show is if, with 6-minute walk distance on the left, if you had physical training you were able to walk much further, as you see with that red bar, compared to the people who had no physical training. And the FAS, which is a 10-question instrument that we use to measure fatigue, got much better, less fatigue in those patients when they were trained versus those elected not to be trained. So finally, what about this thing called cognitive failure, or spaghetti in the brain, as one of my patients called it? My connections are just not there. This is something that can be seen by many different people with chronic diseases, whether you have MS, rheumatoid arthritis, cancer, chronic infections, and sarcoid is certainly on the list. And it's a problem with concentrating and something we call executive functioning or multitasking. The symptoms, again, are not related to the sarcoid. And you can see this even when you have not much granulomatous burden. And this is something your doctor may say, your sarcoid's doing fine, I don't know why you can't think, go see somebody else. But it is a common problem that can be seen in our sarcoid patients. Again, our Dutch colleagues have looked at 340 patients who had chronic sarcoid, and they had them complete that FAS, which is that questionnaire looking at fatigue, and they had them complete another study called the Cognitive Failure Questionnaire. They had a similarly matched group of healthy patients, and they found that the patients that had sarcoid had 35% high level of severe cognitive dysfunction compared to only 14% of their controls. They did find that in some of the patients who received anti-TNF therapy, there was an improvement in cognitive failure. So this suggested that there might be an impact on treatment as well. But unfortunately, they were not able to show that with other forms of therapy, such as steroids or methotrexate. So where are we with this? We clearly need some new directions on how we identify patients that have these parasarcoid symptoms. And I like to tell people as we're working through these problems that you need kind of an integrated approach. It's important to eat healthy, as you see on that left-hand panel. And actually, we were at our big WASOG meeting in Beijing, China last year. And there's a little saying up there, chicken ginseng kui does everything to help with fatigue and vitality. Acupuncture, acupressure, massage, exercise. These are all things that have been tried. Not much science study, but a lot of patient satisfaction reported in trying to make it so that you will be less fatigued. So to summarize, sarcoid is a global disease, unknown cause, sometimes very difficult to diagnose. You need the presence of granulomas, ideally in more than one organ, without other signs or symptoms of infection or tumors or things that could cause granulomas. Do not forget that most patients with sarcoid have an excellent disease. Most patients do not die from sarcoid. Some do, and those are the rare minority that have very serious forms of the disease. Why do we treat? You look for danger, and you look for quality of life. Parasarcoid is a big problem. The big three of fatigue, small fiber neuropathy, and cognitive failure, and much more research will be going into this in the future. When you're thinking about fatigue, make sure you treat reversible causes of diabetes, thyroid infection, sleep and neuro evaluations are very important. And if at the end of the day you really need the battery recharge, things such as integrated strategies or neurostimulants could be attempted as well. And with that, I'd like to thank you and let you all celebrate April, which is Sarcoid.